Welcome back, everyone. We continue our discussion on respiratory disorders, diagnosis, management, and prevention. Today's topic is pharmacotherapy of bronchial asthma and COPD. Asthma and COPD are commonly encountered respiratory disorders that may be associated with a troublesome cough that may be the patient's only symptoms. Coughing is an important respiratory response to irritation and is the number one reason why patients seek medical care. These respiratory conditions can be adequately controlled by a combination of appropriate lifestyle changes and medications. Drugs used can be delivered topically to nasal mucosa, inhaled to the lungs, or given parenterally for systemic absorption. Topical delivery methods, inhalers, and nasal sprays are preferred to target affected tissues and minimize systemic side effects. Drugs used to treat asthma include beta-adrenergic agonists, corticosteroids, cromolyn, necrotidil, ipratropium, montelukast, safirlukast, and xylitol, omalizumab, and theophylline. Drugs used to treat COPD includes beta-adrenergic agonists, corticosteroids, ipratropium, and tiotropium. Now, asthma is an inflammatory disease of the lung characterized by bronchoconstriction, causing dyspnea, cough, and tachypnea. Acute symptoms may resolve spontaneously or with quick relief medications. They are not progressive and will not inevitably lead to crippled airways. It's a chronic disease that, if not treated, will lead to airway remodeling, resulting in increased severity and incidence, or exacerbation, or even death. Now, what are the goals of therapy in bronchial asthma? 1. Reducing impairment. This includes prevent chronic and troublesome symptoms. Require less than 2 days per week use of inhaled, short-acting beta-2 agonists for quick relief of symptoms. Maintain normal pulmonary function. And lastly, maintain normal activity. 2. Reducing risk. These include prevent recurrent exacerbations of asthma and minimize emergency room visits or hospitalization. Prevent progressive loss of lung function, and in children, prevent reducing lung growth. And lastly, provide optimal pharmacotherapy with minimal or no adverse effects. What are the factors affecting pharmacotherapy? First is the role of inflammation. Airflow obstruction in asthma is due to bronchoconstriction from smooth muscle contractions, inflammation of bronchial wall, and increased mucus secretion. Symptoms may be effectively treated by several drugs, but no agents provide a cure. Second is the role of phenotype. There is a link between beta receptor polymorphism or phenotype and response to long-acting beta-2 agonist in 16 to 20% of asthma patients. Patients with homozygous arginine polymorphism may be at risk for worsening symptoms with long-acting beta-2 agonist therapy. If patients report worsening symptoms with long-acting beta-2 agonist agents, therapy should be discontinued with subsequent increase in corticosteroid therapy as clinically appropriate. Treatment of asthma depends on its classification. Let's look at the table. There are 4 classifications. First is mild intermittent asthma, where bronchoconstriction is less than 2 per week. Peak flow spirometry is almost normal. Long-term control is achieved without daily meds, and quick relief of symptoms is achieved with short-acting beta-2 agonists. Next is mild persistent asthma, where bronchoconstriction is greater than 2 per week. Peak flow spirometry is more or less normal. Long-term control is achieved by low-dose inhaled corticosteroids, and quick relief of symptoms is achieved by short-acting beta-2 agonist. Third is moderate persistent asthma, where bronchoconstriction happens daily. Peak flow spirometry is 60 to 80% of normal. Long-term control is achieved with low to medium-dose inhaled corticosteroids and long-acting beta-2 agonist. Meanwhile, quick relief of symptoms is achieved by using short-acting beta-2 agonist. And lastly is severe persistent asthma. Bronchoconstriction is continuous. Peak flow spirometry less than 60% of normal. Long-term control is achieved by high-dose inhaled corticosteroids, long-acting beta-2 agonist, while quick relief of symptoms is achieved by short-acting beta-2 agonist. Let's discuss the first-line drugs in the treatment of bronchial asthma. They include adrenergic agonist and corticosteroids. Now, adrenergic agonist is a drug of choice for mild asthma. direct-acting beta-2 agonists are potent bronchodilators. Adrenergic agonists can be divided into those that provide quick relief and those that are used to achieve long-term control. Now, for quick relief adrenergic agonists, most clinically useful beta-2 agonists have rapid action of 5 to 30 minutes and provide relief for 4 to 6 hours. Epinephrine is a drug of choice for treatment of anaphylaxis. They have no anti-inflammatory effects and should not be used solely in any form of persistent asthma. Direct-acting beta-2 agonists offer advantage of maximally attainable bronchodilation with minimal undesired effect of alpha or beta-1 stimulation. They include terbutaline, albuterol, and pirbuterol. They are not catecholamines and therefore not inactivated by catecholamine O methyltransferase or COMT. Adverse effects like tachycardia, hyperglycemia, hypokalemia, and hypomagnesemia are minimized by the use of inhalers. Now, long-term control makes use of long-acting beta-2 agonist bronchodilators like salmeterol and formoterol. Their lipophilic side chain increases affinity to beta-2 receptors. They have slower onset of action, but bronchodilation lasts up to 12 hours. Their adverse effects are similar to short-acting beta-2 agonists. Next are corticosteroids. Inhaled corticosteroid is a drug of choice for persistent asthma. Severe persistent asthma may require a short course of oral steroids. To be effective in controlling inflammation, they must be taken continuously. Now let's discuss corticosteroid actions on the lung. First, it directly targets underlying inflammation by decreasing the inflammatory cascade, reversing mucosal edema, decreasing capillary permeability, and inhibiting leukotrienes. Next, after several months of regular use, they reduce hyperresponsiveness of airway smooth muscle to a variety of bronchoconstrictor stimuli. Let's discuss the route of administration for corticosteroids. First is by inhalation, which remarkably reduces the need to use systemic corticosteroids to control asthma. Appropriate inhalation technique is critical to successful therapy. Patients should be instructed to slowly and deeply inhale after activation to ensure medication do not lodge in the laryngeal mucosa rather than in the bronchial smooth muscles. Even if properly administered, corticosteroids deposition on the oral and laryngeal mucosa can cause side effects like candidiasis and hoarseness. Second is oral or systemic administration. Patient with status asthmaticus may require intravenous administration of methylprednisolone or oral prednisone. Once improved, doses is reduced gradually, leading to discontinuance in 1 to 2 weeks. Now, suppression of hypothalamic pituitary axis do not occur during short courses of oral prednisone burst therapy, so dose reduction is not needed. Now, lastly, spacers. Spacers are large volume chambers attached to metered-dose inhaler and prevent deposition of drug in the mouth. Large particles are deposited on the spacer while smaller high-velocity particles reach the targeted tissue. They minimize adrenal suppression by decreasing amount of glucocorticoids deposited in the oropharynx. Now, what are the adverse effects of asthma? First, oral or parenteral corticosteroids have serious side effects, especially on bone growth. Meanwhile, inhalers, when used with spacers, have few systemic side effects. Let's discuss alternative drugs used to treat bronchial asthma. They are used to treat moderate to severe allergic asthma in patients who are poorly controlled using conventional therapy or experience severe adverse effects with high-dose or prolonged corticosteroid therapy. They are used in conjunction with inhaled corticosteroids and never as sole therapy. First are leukotriene antagonists. Now, leukotrienes, B4 and the cystenyl leukotrienes, C4, D4, and E4 are products of the 5-lipoxygenase pathway of arachidonic acid metabolism and part of the inflammatory cascade. 5-lipoxygenase is found in mast cells, basophils, eosinophils, and neutrophils. LTB4 is a potent chemoattractant of neutrophils and eosinophils. The cystenyl leukotrienes constrict bronchiolar smooth muscles and increases capillary permeability and mucus secretion. Now, leukotriene antagonist includes the following. 1. Xylotron is a derivative and specific inhibitor of 5-lipoxygenase, preventing production of all leukotrienes. Zafirlukas and montelukast are selective, reversible inhibitor of the cystinyl leukotriene 1 receptor. Montelukast's advantage is dosing recommendations for children 1 year and older, as well as chewable tablet and granular formulation. They are approved for prophylaxis of asthma, but not when immediate bronchodilation is required. Now, what are the pharmacokinetics of leukotriene antagonists? 1. All three are orally active, although food impairs absorption of zafirlukast. 2. Greater than 90% is bound to plasma proteins and extensively metabolized. 3. Xylitol and its metabolites are excreted in the urinary tract. Meanwhile, montelukast, zafirlukast, and its metabolite are excreted in the biliary tract. Now, what are its adverse effects? 1. Elevation of serum hepatic enzymes. Discontinuation of medication is indicated if hepatic enzyme exceed 5 times the upper limit of normal. Also include headache and dyspepsia. Now, both zafirlukast and xylitol are inhibitors of cytochrome P450 and can increase serum levels of warfarin. Next is cromolyn and necrodomil. They are prophylactic anti-inflammatory agents. They are not used in acute management of asthma since they are not bronchodilators. They block initiation of immediate or delayed asthmatic reactions. They are administered by inhalation of microfine powder or aerosolized solutions. It is poorly absorbed with only minor side effects. Pre-treatment blocks all allergens and exercise-induced bronchoconstrictions. A 4 to 6 week trial is needed to determine efficacy. The short duration of action, which require frequent dosing, which can cause problems with compliance. Now, third is cholinergic antagonists. They are less effective than beta-2 adrenergic agonists. They block vagally mediated contraction of airway smooth muscle and mucus secretion. Inhaled ipratropium is a quaternary derivative of atropine. They are useful in patients who can't tolerate beta-2 agonists. They have slow onset and almost no side effect. They are most effective on patients with both asthma and COPD. Fourth is theophylline, which is a bronchodilator that relieves chronic asthma and decreases symptoms. It is well absorbed in the gastrointestinal tract. There are several sustained-release preparations available. They are replaced by beta-2 agonists because of the following. First, narrow therapeutic window. Second, high side effect profile. Third, potential for drug interactions. And lastly, overdose causes seizure or fatal arrhythmias. Its pharmacokinetics include the following. 1 is metabolized in the liver. 2 is a CYP1A2 and 3A4 substrate. And lastly, it interacts with many drugs. Last is omalizumab, a recombinant DNA-derived monoclonal antibody that binds with IgE. Decreased binding of IgE to high-affinity IgE receptors in mast cells and basophils results. This limits the release of mediators of the allergic response. It is useful for treating moderate to severe asthma poorly controlled by conventional therapy. Now we go to chronic obstructive pulmonary disease, or COPD. COPD is a chronic progressive obstruction of airflow. Smoking is the greatest risk factor. It leads to progressive decline of lung function as demonstrated by functional expiratory volume, or FEV. Smoking cessation should be recommended to all patients regardless of age or severity. Now, what's the treatment of COPD? Well, inhaled bronchodilators like ipratropium or beta-2 agonists are the foundation of therapy. They increase airflow, alleviate symptoms, and decrease exacerbation of the disease. Combination anticholinergic and beta-2 agonists may be more effective if single agent fail to provide adequate relief. Longer-acting drugs like salmeterol and tiotropium have the advantage of less frequent dosing but should be reserved for severe cases. Addition of inhaled corticosteroids provides symptomatic relief but does not impact progressive decline in FEV1. Addition of long-acting beta-2 agonists improves lung function compared to using short-acting beta-2 agonists or corticosteroids. Treatment of COPD depends on the stage. Let's look at the table. Stage 1 is considered mild COPD. It's characterized by FEV1 of greater than 80% of predicted. Long-term control is achieved through short-acting bronchodilator as needed. Stage 2 is moderate COPD. It's characterized by FEV1 between 50 to 80% of predicted. Long-term control is achieved by regular treatment with bronchodilator and inhaled corticosteroids. Stage 3 is considered severe COPD. It's characterized by FEV1 of less than 30% of predicted. Long-term control is achieved by regular treatments with bronchodilator, inhaled corticosteroids, and antibiotics for acute exacerbation, as well as long-term oxygen therapy. This ends our discussion on pharmacotherapy of bronchial asthma and COPD.